Hello. Hi, good evening. I'm Dr. Gary Howsam and I'm the Vice Chair of External Affairs at the RCGP, and I'd like to welcome you all to the first in a series of live panel events that we'll be holding from RCGP for our membership. We wanted to be able to speak to you directly about what the college has been up to and what we're doing, working on behalf of our members and our patients during this difficult time. You'll have heard some of what we're up to through our media work, but we really wanted to take an opportunity to discuss more directly with you what we've been doing. And tonight's discussions around the topic of innovation and technology. Each week we'll be broadcasting a discussion on a topic that's related to COVID with some leading figures from the college, and you'll have the opportunity to ask us your questions. You can put those to us through hashtag RCGP Together Live on social media, or if you write them in our online forum, then we've got members of the team scouring that to make sure we pick those up from you during the session. If there's any questions that we don't manage to answer during the question or during the session, then we'll try and get them posted in a blog afterwards. If you've got any questions that aren't about technology, for instance, on training, testing, mental health, or anything else that you think is really important, please do let us know and we'll try and cover it in a relevant Q&A on another occasion. And if you'd like to use the same hashtag to suggest other topic areas, then we'd be delighted to hear from you. So I'd like to start off with very brief introductions from the other people who are on the panel tonight, and then I'll ask them to take an opportunity when they first speak to introduce themselves a little bit further. But we've got Professor Martin Marshall, who's the chair of RCGP's UK Council, Dr. Lawrence Dorman, who's the chair of RCGP Northern Ireland's Council, and Dr. Steph Coughlin, who's our clinical lead for innovation. They'll be able to tell you about different areas of work that we're doing within the college as we go through the course of this evening. I would like to take the opportunity at this point just to say thank you for the RCGP Health Informatics group, which is chaired by Dr. Marcus Bohr. They've been an absolute driving force in the college's response around technology for COVID. And I'm sure some of the work that they've been doing will come up during the course of our discussions this evening. They've been absolutely pivotal in feeding back to the government and the NHS on data sharing arrangements, data extraction in primary care, research, and the NHS contact tracing app. A special thank you to Marcus as well for setting up the college's online members forum, which has been a hugely valuable resource for us as a mechanism for communicating with our members. So Marcus, thank you particularly for that bit of work. So we've had a couple of questions come in already. So what I'll do is if we go straight to the first question, and as I say, if when the panel speak for the first time, they could perhaps give us a little bit of an introduction of what they do for the college, but also where they do their GP practice as well. So the first question we've had in is from Chris via the forum, and he's asking, given the advancement in need and availability of video consultations and other technologies to supplement the consultation and GP services more broadly, for example, people sending in photographs of lesions and things, is this a priority for the college or simply an interest of the college? And how will we be pursuing this going forwards? Because it really has been fundamental to the change in the way we're practicing at the moment. And perhaps I can go to Martin first, please.
So thanks very much, Gary, and welcome to everybody. Thank you so much for joining this event. It's really exciting to have this opportunity to interact with you and to respond to you and hear what you have to say. So I'm Martin Marshall, I'm chair of the college, and I'm a GP in East London in Newham, and I am an academic at UCL, a health service researcher. So I think this is the key question. So as a college, we have always made it clear that GPs embrace technology. I remember in the practice that I trained in down in Devon quite a long time ago, that practice had gone paperless in 1974 with record systems. So general practice has a long track record of embracing technology. And we've been very clear as a college that we feel that patients want and deserve and will benefit from a range of different ways of accessing care. Face-to-face, of course, telephone, of course, but also online, text-based, asynchronous care, whole range of different approaches, and we've really welcomed that. And we see that online care as being absolutely key to what we want to deliver. There are pros and cons to all different approaches to accessing care, but we think as a college, promoting and encouraging the right use, a balanced use of technology is absolutely central to what we do. So I hope that's a helpful introduction, at least, Gary.
Okay, that's great. Thank you, Martin. Lawrence, perhaps I can bring you in here, please.
Thanks, Gary. My name is Dr. Lawrence Dorman. I'm the chair of Royal College GPs in Northern Ireland, and I'm a GP principal in Kilkeel in Northern Ireland. For those of you who don't know our geography, Kilkeel, it's a small fishing village on the east coast of Northern Ireland, just between the mountains of Mourne. The Mourne Mountains form a lovely shielding area just between them and the sea. So it's a beautiful part of the world if any of you, after lockdown, get to visit it. So our survey, we were very keen to push our survey hard. We extended our survey because we really wanted Northern Ireland members to feed into it. And our results sort of mirror very closely to what you guys have been finding. We've been finding that 40% of GPs have not been able to work remotely during the pandemic. And we think this is very important because what this will allow us to do, it'll allow us to utilize our workforce to its maximum. So if people need to work at home, allowing them and enabling them to work at home will be really important. What we did find was that network issues were a problem with about 40% of those working at home, and about 52% people who were working at home were having difficulty getting a laptop. And we know this because we speak to our GPs on the ground, as you do, Gary, and as Martin does as well. And when we speak to our colleagues on the ground, they were telling us at the start of COVID, there was a rush for everybody to rush out and buy things because they couldn't physically get enough. So we're really using this survey to engage with our government and to get them to work with us, to give us the resources that we need. The tech survey has been really helpful because it allows us to open up this big discussion more widely. We found in Northern Ireland, the tech survey was quite focused on working from home, but as we all know, that there's much more to this. So we're keen that this opens a bigger discussion. I think we were wise as a college, to have quite a clear focus within this discussion, because if we just opened it up for everything, it would be a very big discussion indeed. We're really keen that this opens up more and we can talk about more of what technology can offer us.
Okay, that's great. Thank you, Lawrence. And perhaps, Steph, I can come to you. And maybe a lot of people out there might not know that we have a clinical lead for innovation. So maybe you could tell us a little bit about what your role pre-COVID was inside the college and where you've been in the last couple of months as this has really come to the surface.
Yeah, well, thanks very much, Gary, and it's great to be able to join the panel this evening. So I'm Stephanie Coughlin, and I'm a GP in Hackney in East London, and I'm clinical lead for innovation here at the college. And actually, the innovation team have been working pre-COVID on a whole variety of projects, and in some particularly relevant ones now. We're doing some work around continuity of care and what that looks like. Also some work around digital therapeutics, so thinking around wellbeing apps and what evidence and standards look around that, but really now focusing with the college team on what a transition and recovery post-COVID looks like. And just going back to what Lawrence was talking about the survey done in Northern Ireland, actually we've done our own survey here in England, actually had an amazing response over a very short period of time where a lot of similar themes around technology came up. It's a really exciting time, and actually for some it's a burning platform we've been waiting for to make some changes, but actually we know that basic IT and hardware and access to those are a challenge, and we know that mirroring the Northern Ireland results, about 50% haven't been able to access remote working because of technology, and VPN connections have been a really big issue. So actually, thank you to everyone who's responded to the survey, and actually it really gives us some incredibly valuable on the ground information to take forwards.
Okay, thank you, Steph. So I think what your answer highlights is that the innovation and the technology arena is one that was a priority for the college prior to COVID. And I think, there's the old adage about not wasting a crisis. And actually, a lot of people who had been reticent about taking up the opportunities to use some of these technologies in their surgeries have had their arm twisted, if you like, and forced to embrace them. It was really important to us as a college to understand the barriers for our members. And I think both Lawrence and Steph, you've touched on some of the issues that people had around the hardware, around broadband connections. And it was difficult enough to instigate this when we were all working from our usual buildings, and with the added challenge of having to be working from home as well. That's just added a different angle. We've got a follow-up question from Chris, who's asking what efforts are being made to avoid any element of perceived bureaucracy in supporting this position within teaching, assessment and maintenance courses. He says, ultimately, I'm asking, can the college roll this programme out within a year? Now, what I haven't mentioned is I'm a GP up in Peterborough, but I also chair a clinical commissioning group, and a potentially small amount of investment in this technological equipment, the laptops, the webcams, the speakers, the headphones and things like that, has absolutely revolutionised the way we're able to deliver things. But that's because we've been given the special COVID budget line and a green light to invest in these things. So how are we going to make sure that we don't let bureaucracy get in the way, Martin? Obviously, as a policy leader for the college, is that something that you're considering, and do you have any answers for members who might be worrying about that?
Yeah, so I think it's exactly the right question, isn't it? Because we have to move really quickly in order to maintain the benefits that we have seen, but also to push back on some of the technology-related COVID changes that we perhaps don't want to see embedded in the service long term. So as far as the college is concerned, I think our general response to the COVID pandemic has been really quick. I mean, I do understand that the college is sometimes criticised for being a bit stodgy, a bit slow to move. I think over this COVID crisis, if you look at what's been developed in terms of support for our members and support for general practices in particular, our work with bodies, all four governments, for example, in order to get changes has been phenomenal. So I think the college has demonstrated its ability to work at pace, and we must continue to do so. But this is about more than the college. The college can produce learning materials, it can lobby governments, it can lobby arm-length bodies in order to facilitate these activities, but it's also about those bodies themselves acting quickly. And during the COVID crisis, they've demonstrated their ability to do so as well, I have to say. Some of the, as Gary says, the funding that's gone into technology, just in my local area in Newham, I'd not done remote consultations in my practice prior to this COVID crisis. Within about 2 weeks of the crisis happening, Newham had provided me with a laptop with records on it, with a secure VPN connection, and I was within a week up and running and doing remote consultations. That's the kind of thing that we need to do. And it was actually, as Gary says, it's a tiny amount of money to provide those kind of extra technologies for GPs. I don't know how much it was, 1,500 quid. You know, when you look at the overall cost of healthcare, it's a fraction of what we're spending, and yet it gives us flexibility. It introduces new people into the workforce. Wouldn't it be wonderful if we managed to retain some of the retirees, the returners in the workforce doing this kind of work? I think the potential is just enormous.
Okay, thank you, Mark.
Sorry, can I come in there, Gary, as well? In Northern Ireland, we're doing things differently as well. And so some of the enhancement programs, you know, such as Accurix and Zoom that are attaching onto our computer systems, it's really important that we utilize these going forward. And there's definitely a big role for the college in Northern Ireland to provide training for people. I think all of us have learned on the job how to use these functions. And most of us, if we're honest, we're only using them the initial bit of the function. You know, we've learned the easy bits, but to get an expert to really show us the full capability of these would be great. And I can definitely see a role for the college to help us with that.
Okay, thanks, Lawrence. I mean, Steph, we've had discussions previously in other areas where we've said that if you give GPs a challenge to fix, if you give them some time, and if you give them the freedom to innovate, then they will come up with a solution that suits them. We often get tied up in saying, you know, have we got the evidence? Have we got the proof that this is good? But people have innovated and tried different things, and we've moved very quickly. And the stuff that's not worked, we've turned off. But we've held on to a core of new technologies over the last couple of months. What do you think about the challenge that some may be saying is that we shouldn't be blindly adopting this without having a research base to justify its use?
I think it's a really good question. I think one thing that the last couple of months have really shown is the process of rapid test and learn. And so actually how local areas have used that cyclical approach to start something very quickly, but actually then if it's not working, stop it and change. And so I think that there has definitely been a culture change into how we can adopt innovations and technologies, and actually giving us the confidence to quickly identify if something is working or isn't working. So I think the culture change, and I think you know, to credit to GPs across the country, actually flexibility, adapting very quickly, and being open to new ideas and open to new ways of working very quickly. I think all of those together, I think have definitely changed the landscape going forwards.
Okay, thank you. Obviously, whenever we bring in a new tool like this to facilitate us with our interactions with our patients, not everybody's going to be able to adopt it at the same pace, either because of logistical reasons or maybe they haven't got the broadband connection. So what's the college done to highlight areas of inequality where that technology isn't accessible? Maybe Lawrence, can I ask you for your view on that one, please?
Yeah, so we have used this survey, you know, to highlight things that we don't have. So there's areas of inequality, and we are worried about people. You know, in 2018, I think, I mean, the college showed, or there was a survey done that showed only about 8% had appropriate digital skills, and we are very worried about people who are older, who are homeless, and who won't have access to digital services. It's also highlighted inequalities in Northern Ireland in what we can offer GPs that maybe people would have in the mainland, so other GPs would have in the mainland, and inequalities between GPs. So for example, in Northern Ireland, we don't have electronic prescribing, which I think is more widespread over in Wales and in England. And using things like the survey, we have been able to bring this up to government and to our permanent secretary and highlight this, and to highlight how investment in an electronic prescribing benefits not only the whole health service, it makes my prescribing safer towards the chemist, but it helps our whole society. It reduces footfalls into our practices. It helps reduce, you know, carbon dioxide levels. It keeps people off the road. So there's big benefits to society, but only by having these data and by getting good GPs to participate in these surveys can we bring these to governments.
Okay, and Martin, have you had the opportunity to speak to anybody in the ministries or the department about any of these shortfallings in the availabilities of technologies, really to advocate for those colleagues of ours who are really struggling to get on board with what we can see has the potential to be a very new way of working?
Yeah, so I think the issue of inequalities, unequal access is a massive one, and as Lauren says, it relates both to GP, if you like, you know, our provider role, inequalities there, but also in terms of patients as well. So from a GP point of view, yes, the college has been lobbying for a long period of time to improve our access. It's about broadband availability. We know that that isn't available in many parts of the country, particularly in remote rural areas. That can sometimes be a problem. It's about the availability of the equipment. It's about the availability of the skills. So we've been lobbying for a long time to ensure that everybody comes up to a reasonable level of provision and a reasonable level of training and skills to allow them to use the technologies. I think the inequalities at a patient point of view are really important to us, because one of the things that we do as GPs is hold a kind of community health, public health type responsibility. Excuse me. And we see the inequalities in the front line. Technology has the potential to exacerbate those inequalities, but it also has a potential to alleviate those technologies. And you know, as an example of that, we know there are some people with mental health problems, for example, who would much rather access care through technical solutions rather than traditional face-to-face. We know adolescents are often an underserved group. They're more likely to access care through using technology as well. So I think we have to think really carefully about the inequalities agenda, but we have to actually utilize technology in order to address these long-standing and deeply embedded inequalities that we see.
Thank you. And I think it's often very easy to jump to stereotypical ideas of those that might be struggling with the technology, sort of the older patient population. But I think when we've had discussions beforehand, anecdotally, we're finding that a lot of people do have access, and it's not usually just based on age. We've got plenty of older patients who are able to use the technologies and finding it particularly helpful, especially if they've got mobility issues, so would struggle to get down to the surgery, and now they can use these technologies going forwards. It might actually make it easier, as well as those other groups, the mental health patients and the adolescents that you mentioned, Martin.
I think that's right, Gary. But it's certainly about having the technology and being able to use it. But it's also about having the health literacy in order to be able to understand what it means, and we mustn't forget that step because it's really a central part of it.
Yeah, Steph, I was just wondering if I could pick up on something that you were talking about earlier on, because you mentioned you're doing some work around continuity of care, and obviously that's a massive issue for us when we were sort of consulting in the old ways, if you like. Can you tell us a little bit more about that work you've done and how you think that might be changed by the change in the way we're interacting with our patients now?
Yeah, thanks, Gary. So here at the college, we are working with the Health Foundation and a number of pilot sites across the country to look at what continuity of care looks like and what works, both from named GP lists, relationship-based care, but also micro teams. So actually the change over the last couple of months, I think from on the ground perspective, actually continuity of care in lots of ways has become even more important than it was before, but actually our continuity is happening in different ways. And actually does the change in technology, the questions that we're asking, is that making continuity easier? How is continuity impacted on it? So I think it's really great that we've already got this project happening now, and then actually as we start to get into the autumn, we can think about how some of the digital solutions and tech solutions that the sites have been utilising, as well as other ways of working, have been impacted by the COVID pandemic, and actually what's the learning. So there will be information and learning that we'll be able to share towards the autumn.
That's brilliant, thank you. Martin, I wonder if I could pick up on two elements of the new ways we're working. When you became chair of council, you're very interested in workload and also relationship-based care. And we hear from other areas of the health arena that perhaps now GPs are doing less face-to-face consultations, that this has generated a large amount of capacity. But that doesn't feel quite right to me when I'm sat in my practice. I just wondered if you had any reflections on that bit, and then perhaps in a while we could pick up the relationship-based care part.
Yeah, so the figures around how general practice have changed as a consequence of this crisis are really dramatic. So we know that prior to this crisis, this is data that comes out of our Research Surveillance Centre, which is based in Oxford, pretty reliable data. Prior to this crisis, around about 70–75% of consultations were carried out face-to-face. Now it's around about 15% according to the data. Actually, in my experience in East London, it's even less than that. In terms of activity, we know that the number of consultations has dropped by about 25%. Of course, consultation numbers is only one thing, because we know that GPs are doing other things as well. But we know that the workload, the non-clinical workload, administrative responsibilities have dropped by 28%. Now, some people are saying, so general practice is quiet. It isn't. It seems to me that we were working at 120 or 130% of capability and capacity prior to the crisis, and we're now down to something that actually is doable. I think we really do need to see technology as one of the ways of ensuring that we address the workload crisis and we keep the workload in a manageable level. That's going to require us to differentiate between where we can really add value as GPs and where we can't, where it's a doctor's business and where it's other members of the primary healthcare team. So I think there's lots of really big strategic issues that the COVID crisis gives an opportunity to address.
Okay, thank you. Perhaps, Lawrence, I could ask you a question around that. We've obviously got the technologies in our surgeries now. Can you see any roles for these technologies for the way we interface with secondary care? I know you've done a lot of work in Northern Ireland around sort of communicating with colleagues in secondary care through the more traditional routes, but I wonder how that's going to look now with using more technology, or I shouldn't say that, more advanced technological solutions.
Yes, yeah, and you're right, Gary. So in Northern Ireland, we have done a lot of work between the other Royal Colleges. We have our principles document, which all 14 Royal Colleges in Northern Ireland agreed to, and it was about how we got back to basics, about courtesy and respect, and everybody signed up to that. But now we need to take it to the next level, and I'm actually delighted that through this work it has showed the best of us. So Things like ambulatory units are being opened up in Belfast, and they're being opened up as a partnership where everybody recognises each other's roles and how we can best come together to serve our patients better, and focusing on our patients' journey and how that relationship between each other is just so important. But the use of technology can be really important in all of this. Do we need to be communicating? We've found video conferencing has been very helpful, and we've found learning through video and through technology very helpful as well. Our secondary care consultants are very keen to be involved more now in our teaching sessions, so we all learn together. Northern Ireland has run a project called Project Echo, which is a national service which recognises that everybody is a teacher, everybody is a learner, and those sessions have been very helpful. And one of the big things that we've come out through this is that there has been developed a dedicated website in Northern Ireland called GPNI. And that's been a multi-agency website. The colleges had representative into it, between the college, our postgraduate department, NIMTA, through Queen's University, and our GP federations. And it's been a really good example for harnessing, technology through website learning, through webinars, and so the communication in a lot of ways through that with our secondary care colleagues has never been better. And this has really been an opportunity that we've used.
Okay, thank you. I'm doing a piece of work with the Royal College of Physicians at the moment, which is looking about how we use this new technology around referral and bringing in expert opinion when we've got issues with our patients. And one area that our patient group at the college actually flagged up was the potential for a sort of three-way dialogue between the patient, the secondary care specialist and their GP, all being able to be on a video consultation at the same time. Has anybody got any experience of trying to do that sort of thing in the past, and can see any benefits and how that might be easier going forwards? So Martin, you're nodding your head.
Yeah, so yes, some experience. I mean, it seems to me that the traditional outpatient model is the most unreconstructed part of the NHS. Having to refer somebody into often a nameless service nowadays, an anonymous service, and then having to wait for weeks or months in order to be seen, and then having to wait for several weeks for a letter to come back is just crazy. And the opportunity to use technology to replace a lot of the waste that goes on in outpatient services, I think, is phenomenal. So in East London, we have access in a range of different ways to our specialist colleagues, using telephones, using online, using three-way video-based consultations between the patient, the GP, and the specialist. We have really good ways of transferring data between the different sources, and it just works phenomenally well. I don't see any reason why that can't be rolled out across the UK. I think we have to remember that the general practice does, by and large, have better technology and better understanding of technology than our hospital colleagues have. So it's going to require significant investment in hardware and software within hospitals, but that must be the future.
Okay, thank you. Steph, I was wondering if I can ask you a question, please, on a theme that's starting to emerge. And you said earlier on that we've been trying to get these changes to happen for a while. We've kind of reached that burning platform that's given us the impetus, that slight nudge off a cliff edge, which has really promoted the change in the way we're behaving. As we look to the future, I think it's also probably a good idea just to look back and try and reflect on some of the barriers to change that were there before. Have you got any reflections around that? What may have been stopping us previously, so we can learn from that, so we don't sort of sit too tight on other opportunities that might present themselves in the future?
Yeah, Gary. So I think thinking about barriers, what have been barriers in technology and innovation? I mean, and actually, Martin talked about one of them earlier around workload. Actually, when you are working at 130%, having space and capacity to think about change takes time, it takes investment, it takes energy. And actually, when you're flat out, it is difficult to be able to find the capacity to do that. So actually, our workload has not decreased. It's just that it has become to a more manageable level and a more appropriate level, which has given us the space. I think the other is around workforce as well. There are differences across the country, and that those sometimes it doesn't matter how much technology you have, not having a stable workforce in order to implement technology is a real challenge. So actually there is lots of work that we need to be thinking around supporting those areas which are struggling with whole-time equivalents of GPs, because actually we still need workforce in order to be able to implement it. So, I'm really interested to understand how those areas who have less whole-time equivalent GPs have managed throughout the past couple of months. And then I think the other is, Lawrence talked earlier about Accurix. Actually quite an altruistic company who have got what we needed, who have been there, who have, they're one of several, but actually it's one who were there when we needed them, and actually were able to support us with very quick rollouts and actually listening to what we wanted and needed. So I think having companies who were there has also been incredibly helpful, and perhaps didn't necessarily have the impetus or there wasn't the need for it before to support us in these different and more altruistic ways.
Okay, thank you.
Can I add? Oh, sorry.
Yeah, so Lawrence, and then to Martin, please.
Yes, so some of the remote working hasn't actually increased our capacity. It's just allowed me to work at my desk from a different place. So it's very important, as Steph says, that we keep, focusing on workforce. We will need, more GPs, when the workload comes back to normal again. But also we're quite reliant on my desktop being open for me to work remotely. So if somebody else is taking up my slot, as it were, in the practice, it doesn't put any extra capacity into my work. So that's really important, that it's seen in a bigger picture.
Okay, thank you, Lawrence. And Martin?
Yeah, I was going to say the same. I think Lawrence is exactly right, that I do 15-minute consultations, and if I'm doing a proper consultation on the telephone or a proper consultation on video, it still takes me 15 minutes. So whilst policymakers think they're going to get enormous efficiencies out of using technology, I think the main advantage, well, there are a lot of advantages, but one of the main advantages accrues to patients because it's more convenient, and that's fine. That's important. That's what we're here for. So I think that's a key issue. I think Stephanie's exactly right in her description of the kind of facilitators and the barriers. One of the important facilitators, I think, is patients' willingness to engage with technology, which has happened as a consequence of this crisis. They've had no choice in the same way as we've had no choice, and patients have discovered that both telephone and video technologies can be really good ways of accessing care. So I think that's important. I mean, we do have to remember that this isn't the death knell of face-to-face consultations. Face-to-face consultations are just fundamentally important, but I'm sure, Gary, you're going to come back to that.
Yes, I will do. And I just want to pick up on one point you've made there, because we've had a question coming from the Northern Ireland Council patient group saying that now GPs are embracing this new technology in their surgeries. You've highlighted a couple of the advantages around convenience. And we've talked about people who have mobility issues, perhaps not being able to get to surgeries, but being able to access doctors better now with the technology. But can you think of any other advantages from the patient side of the consultation? Perhaps Steph, can I ask you that one first, please?
I think just going back to what Martin said, I think there is something here about placing value on remote consultations, and actually both across primary and secondary care. And actually these aren't triage. These are no less value than a face-to-face consultation. And whilst face-to-face is crucial, and some are, I imagine some surgeries out there are also reaching the point where they've been trying to manage some patients remotely for a couple of months or 7 weeks or so, and are now at the point where actually I think we need to have the face-to-face at this point. So I think we need to remember that remote consultations and virtual consultations are one part of a whole package in general practice. I think from the patient's perspective, the advantages are convenience. Actually, some patients find it easier easier to talk to us remotely, and to build trust and to test us and to find out whether we are the right, the right kind of doctor for them. I think that one thing that will be interesting to see is that using remote consultations has been easy during a lockdown period. So one thing I'm quite interested to see is that as we move away from lockdown and as people start to do their more normal activities and aren't quite as home-based, I'm interested to see how remote consultations possibly come into their own there. Are people able to fit them in better in their lives as well? So I think there are lots of advantages for the patient, but we need to make sure that we recognise it's a one, and that we don't get into a position where actually technology is a barrier to us then actually bringing somebody in to see us, because that face-to-face contact is incredibly important for a whole host of reasons.
Yeah, and I think that face-to-face contact and that relationship that we build with our patients is something, Martin, that is very central to the work you want to achieve over the next few years. Is that something you could just give us a bit of an update on? And if sort of video consultations are the future of general practice, do you think that's true, and how would that impact on relationship-based care?
Yeah, so this concept of relationship-based care, which is a slightly clumsy term, but I haven't got a better one at the moment, I think is fundamentally, it's a foundation on which general practice is built. So we know that some of what we do in general practice is relatively transactional, it's relatively straightforward. It may or may not require the skill of the GP, the expert medical generalist, but it's pretty straightforward, and using technology is a really good way of achieving it. Relationship-based care is the difficult bit of general practice. It's a bit where we really add value, and I would say it's a defining characteristic of what we are as GPs. It's what differentiates us from many other branches of the medical profession. And I think it's important, we're probably starting to understand what the elements of that relationship-based medicine is. We know it's important, and there's growing evidence that relationships are as important and as powerful an intervention as prescribing drugs often. The things that we can do when we know somebody and somebody trusts us in terms of not over-medicalizing a problem, prescribing social interventions rather than medical ones, of not doing excessive interventions, not doing investigations, not doing excessive referrals. All of that is a fundamentally important part of what we do, and it's absolutely core to us in general practice. So I've always believed that the face-to-face interaction is an important part of that building of a relationship and building of trust, which allows you to be effective as a doctor. And the elements of that, I guess, are the different kind of relationship you have when you're in the same room as somebody, the ability to shake hands with somebody, the ability to hold somebody's hand, the ability to see the non-verbal communications, the ability to lay on hands. Some of it's symbolic, some of it is very practical. It all seems to be a really important part of the interventions that we use as GPs. Now, so that's why I think we still need face-to-face consultations. What I don't know is how much of that we can deliver remotely. To what extent can you develop meaningful relationships, sometimes over a short period of time, using technology? And teenagers might have the answer to this, might they? Because they develop technologies relationships very quickly and very easily online. Indeed, even some older people used to do with their pen pals. There are ways of interacting with people that don't require face-to-face contact, but I think we need some evidence to guide us there as to how possible it is. And in the meantime, I think as GPs we need to hold on in a very kind of precious and defensive way to the face-to-face consultation, because it is what we are. If you'll excuse my terrible use of the English language there.
Okay, I'm just going to bring in one other question we've got here, because you've had one from Sapna, who's a GPST3, who's saying that the change is not increasing capacity, but it allows more flexibility in time allocation for each patient. So it can be quick for simple cases and longer for more complex patients. So patients aren't hanging around in the waiting room unnecessarily if someone's running late, and therefore not getting upset. So that sounds as if it's beneficial for some of our patients, but also beneficial for the doctors, because we know a lot of them find it very stressful if they're running late. And that concept of stress for doctors is one I'd just like to touch on here, because Some people are suggesting that actually, if we all start working remotely and we're all hunched over a laptop and a webcam, then how are we going to make sure that we sustain those relationships with our teams and within practices? And I just wanted to, Steph, because I know you've done some work around micro teams, if you've got anything you can say on that area.
Yeah, I mean, I think very similar principles apply to those practices that have very large teams who may not work on similar days, and actually so don't necessarily see each other. So how do you establish team and a sense of team around that, and in the micro teams, making sure that often a micro team may not always work on the same day to provide continuity across the week. So how you use technology in order to find a way of communicating with each other, and making sure that you're taking the time to share learning, and actually not meaning that remote working or working in large teams means that people can feel quite isolated, and actually remembering that people's home situations can also have an impact on stress levels, and remote working, whilst for some may be blissful, actually for others can be more stressful than being in the practice. So actually I think again it's just not a one size fits all, and then thinking about remembering how we create a sense of team is important, how we do social activities together, having lunch, all those sorts of things, you know, the coffee, the chats over coffee, and actually how much we all value those. So actually it's really important point, can technology support in that, and that technology is not just about the remote consultation, but actually can be used, you know, just as people are doing quizzes, although I think some people are getting quiz fatigue on Zoom, but as people are doing quizzes, actually how you might use technology to create that sense of team and belonging, which we all know is an incredibly important part of morale amongst our staff and teams.
Okay, thank you, Steph. I mean, one of the discussions we're hearing more and more is that we're talking about these technological tools for facilitating a consultation in a different way, and the impact that that might have on workload and workforce numbers. But there's a group of thought that it's very much around, we need to employ, if you like, non-human digital triage at the front end if we want to make any difference to actual capacity for doctors to spend time with their patients. Lawrence, have you got any views around that aspect of using maybe more advanced technology, not just as a tool to do things the way we've been doing them in a different way, but to actually to signpost or triage patients out, so the ones that really need our skill set have more time with us as their family doctor?
So we're very lucky in Northern Ireland in that we've got a very active patient group, and they've been very good about doing various campaigns. And one of the campaigns they ran last year was a campaign called 3 Before GP, which the college ran as well, but our patient group in Northern Ireland really helped to promote that and promote about patients accessing other things like pharmacy and online resources. But the problem with that, Gary, was to get trusted online resources. So our patients were guiding people towards that. In terms of things like artificial intelligence, it's a tricky one, because we all know that so much of our job is based on the whole person, and there's not just a straightforward disease. It's always how that disease impacts that person and impacts that person in that stage of their life. So there's some things that can be done with artificial intelligence and so on, but I think the role of the generalist has to take in a lot more different things.
Mm-hmm.
Okay, and Martin, you wanted to come in at that point.
Yeah, so we use a package called eConsult as in part at least our front end in our practice, and it's quite a good kind of stepped triage approach. So a patient goes online if they want to. The first question they're asked is, have you got a kind of problem? You put your symptoms in. Have you got the kind of problem where self-care is fine? In which case, here's some resources that will help you to do that. The second question is, have you got the kind of problem that could be dealt with through other resources like a community pharmacy, for example? And then the third question is, do you need to see someone in the general practice team? In which case you're then triaged to the right person. So I think that kind of system can work quite effectively. I think we have to be really careful about downgrading triage. To me, triage is one of the most sophisticated things that we do. And if you watch an experienced GP triaging, they bring a very different approach, particularly in terms of managing risk, to somebody who's relatively inexperienced or perhaps who hasn't got the same level of training. So I think that's important. As far as AI is concerned, of course it has potential. I think a learning system that will help to take on board different symptoms, different signs, and come up with diagnoses is going to be helpful. I still think we're a long, long, long way away from that actually being useful in practice. And anybody who reads Dr. Murphy online will see lots of interesting examples of where some of the current chatbots, triage type systems, have made some pretty sometimes embarrassing and sometimes dangerous mistakes. So I think we need to be very careful, a little bit cautious about how AI can assist triage.
Okay, thank you, Martin. And I think, Steph, you wanted to come in on that point too.
Yeah, I wanted to talk a little bit about the work that we're doing at the college around digital therapeutics. So Martin talked about eConsult using and signposting to other digital solutions. And we know that I'm sure many of you use things like Headspace or other such similar digital solutions. And actually we're looking at putting together some resources to support members around understanding regulations, evidence, validation, because actually we know that if, as a GP, if we are signposting someone to a digital solution, there's implied trust there. That we know that where we are sending the person to, that we feel that this is a good place to go to, rather than perhaps a patient doing a Google search and just finding something themselves. So we are doing some work at the college to support GPs around evidence and validation of that. And I think that's some really good work, which will be helpful going forwards.
Okay, thank you. So, I mean, we've talked about a lot of the changes that are happening, and I think over the last 8 weeks, and certainly in the first couple of weeks, the consultations were so centered on COVID symptoms and whether someone was running the risk of having caught COVID, that they became very transactional and very doctor-centric. How are we going to make sure that we maintain learning and from the experiences we've got over the last few weeks, make sure that we go back to being more patient-centered? Because I think, Lawrence, you've talked about it. The technology might be very good for the medicine bit of it, but we pride ourselves as GPs as seeing people's woes, illnesses, disease in the context of their lives and their psychological response to that. And how do we make sure that we get back to that element of what we know as a specialty we do best?
So in the College in Northern Ireland, we're opening up a bigger debate about this. So what we want to see is what the GP will look like after this. And on Monday night, we're going to have an extended council meeting, where we get everybody's views. It's going to be an extended council, not in terms of time, so people don't need to panic about that, but extended in terms of the people we're inviting into it. So we're inviting our entire council, our entire executive, we're inviting all the federation chairs, we're inviting our head of appraisal, because we want to know all these great people about their views about how we take what's been the best bits of this and what bits that we feel that haven't helped us so much. So you're quite right, Gary. Things that enable us to get to the crux of not just what's the matter with people, but what matters to them, and how we can best support them, in their lives, and how COVID has affected them in their lives. What we do anticipate is that there's going to be a big mental health need coming from this, and we are seeing already patients with anxiety and patients with existing mental health conditions, are getting those exacerbated. So while social isolation and social distancing is maybe quite good for preventing the spread of viruses, it's not very good if you have a significant mental health illness and can quite frequently exacerbate that. In Northern Ireland, one of the plans for us to move our health service forward was through a multidisciplinary team model, where we would have had mental health workers in place and social workers in place. And we've made direct appeals that we feel this bit could be accelerated. And the benefit of having a mental health worker and a social worker embedded in our teams, who could do a lot of work, when we do come out of the pandemic, with that population of our patients that really need a lot of work, and actually who need a lot of proactive work at the moment. At the moment, we're sort of cautiously waiting for people to get sick and people with mental health illness to get sick. We feel if we have these teams embedded in our practices, we can use them to reach out proactively to see how people are doing, rather than just waiting for a crisis to occur.
Okay, thank you, Lawrence. What I'd like to do now is move on to another question we've had in, and this comes from one of our trainee community. And I'm going to ask you, Martin. It's from a trainee who's in their final year, haven't sat the examination yet to get their CCT, and they've heard that that's going to be replaced by video and audio consultations. They're asking how it's going to work, but I just wonder if you could give a general update, because there's a cohort of colleagues who are very worried about how they're going to get to the end of their training in the necessary timeframe. And I know you and officer colleagues have been working really hard around the clock to get a solution on this. Yeah,
so thank you for that question. And it has been really tough for our trainees, particularly the ST3s, during this crisis, because I guess most people on this webinar will know that we had to cancel the exams in early March because of social distancing, because of the crisis, and that left around about 1,500 trainees who would otherwise have taken their AKT and CSA in order to get into independent practice, pass their exam, get their CCT, get into independent practice by August, September time. So it's created something of a significant challenge for the college, but not only for the college, because it's required close working with the GMC, close working with the health education bodies, with governments as well, and with others in order to find a solution. The college is responsible for setting the exam, and we put forward a number of solutions to a wider partnership group a couple of weeks ago. And the preferred option by the whole group was to replace the CSA, which is very difficult to do at these times of uncertainty, when we still have social distancing and we still have concerns about being able to travel. So to replace the CSA with videos, essentially. And those videos, the process is currently being designed at the moment. The expectation is that trainees will record a range of videos from their surgeries. Of course, in the current environment, they won't necessarily be, they probably won't be face-to-face. They might be online video or might be telephone consultations, but they'll record those and submit them to examiners, who then will independently examine them and make an assessment. So the idea is that the quality of this assessment should be similar to the CSA, which is a tried and tested examination with good reliability. Of course, it will be delivered in a different way. It will be, it's a real challenge to deliver it, it has to be said, but the exams team is working incredibly hard in order to get the process right. And further details about the number of videos, how they'll be assessed, what types of videos will be forthcoming very soon, we hope. At the moment, we're taking the proposal to the General Medical Council, which is going to make the decision about whether it is acceptable as a form of assessment. Once we've got their approval, then we'll be able to get going and inform trainees as quickly as possible. What we're hoping is that that examination will be available from late June into July, so that people will be able to take it and get into the service as quickly as possible.
Okay, that's great. Thank you very much for that, Martin. I hope that's provided some reassurance for that cohort of colleagues out there that we know have been particularly worried about what will be happening with their assessments and their ability to get their CCT. We're getting towards the end now, but what I would like to do is just ask you, Martin, again, sorry, just to talk a little bit about one of the other initiatives that the college has run, which has been absolutely phenomenally successful. And we were worried about those people that weren't going to be able to access work experience prior to application for medical school. And it's another of the officer colleagues here who set up Observe GP. I was just wondering if you could briefly mention that, please.
Yeah, so Mike Holmes has done a phenomenal piece of work with our membership team on Observe GP. It gives an opportunity for people over the age of 16 who might be thinking about studying medicine to experience general practice, to get a feel for what it's like, and then hopefully to get into medical school and choose general practice as a career. And we've had amazing take-up of it, phenomenal level of interest. Maybe it's because there's lots of 16-year-olds sitting at home wondering what to do with themselves, I'm not sure, but absolutely phenomenal, and an incredible sense of excitement about how important general practice is. When I decided to study medicine, I was probably 14 or 15. My view of medicine was general practice. That's just what I thought medicine was. But I know a lot of people think that medicine is what you do in hospitals. It's becoming a surgeon, becoming a physician, whatever. These people who are being exposed to general practice and seeing what a fantastic job it is, the variety, the challenge, have become very excited by it. And we've had so much positive feedback from these people who now want to not only study medicine, but get into general practice as well, which is just brilliant.
Excellent, thank you. And we've had another question come in around what's the role of local faculty boards in this crisis, and what innovations have the faculties come up with? Now, I know that you and Mike again have been having discussions with the faculty chairs, and we've got meetings in the weeks coming up, and hopefully that'll be an area we'll be able to discuss. So the roles of the local face of the college out in our faculty network, and the contribution they can be making. We've already seen some changes we had a council meeting or pre-council meeting last night via Zoom with almost 70 of us on there, and I know a lot of faculty boards are meeting by Zoom, but there's opportunities around sort of education and CPD being delivered in the same way. I wondered if any of you have any comments on that at all. Perhaps I can go to Lawrence on that one.
So Gary, we're quite in Northern Ireland. We're quite unusual in that we're a devolved nation, plus we're a faculty as well. So we sit in both camps. So we do. Like I say, we're still reaching out to our members. We haven't been able to, unfortunately, to do the educational events. We had a lot of educational events, like a lot of people had, which were due to be face-to-face. So we've had to put the pause button on those. But we're still there very much for our members, and we still field, phone calls and so on that the normal office would. Reaching out to people through social media and so on, and we're still very much behind the scenes involved with government, trying to shape the agenda, trying to promote the value of general practice. And just to bring back Martin back to his points there, about Observed GP, and also to our ST3 colleagues, it's very important that we raise the profile of general practice and show what a great career and profession it is. And later on in the year, I'm very much looking forward to welcoming our ST3 students whenever they do pass their exams to come and join our workforce.
Excellent, thank you, Lawrence. We're into the last few minutes. Steph, I was wondering if I could ask you, what one thing haven't you missed about the way you've been working in the last 8 weeks, and which bit do you really want to keep tight hold of and amplify as we move forwards?
The one thing I haven't missed running an hour late. I think that's the one thing I haven't missed. And the one thing I want to hold on to is the sense of camaraderie and the sense of coming together. That's actually how we've embraced technology to do that. So actually how we've utilized remote tech solutions to involve our wider practice team, particularly those who are shielding. We've got a number of pregnant members of staff and other people who haven't been able to come into the practice, but actually we've managed to get them, they've been keen to continue to work and keen to stay involved. So I think they're the things that's definitely the thing I want to keep.
Okay, thank you. And Martin, perhaps I could ask you, what's the most exciting thing you think's changed over the last few weeks, either in terms of opportunity or stuff we're already doing that you can see us carrying forward in the future?
Oh, I thought you were going to ask me the same question as you asked Steph. But I could actually give you the same answer, actually, because one thing I haven't missed, and the most exciting thing, I think, is the space that's been created for general practitioners to do the job that they want to do, to provide the quality of care that they want to do. That's partly a reduction in number of consultations, but a lot of it is a reduction in administrative tasks and unnecessary bureaucracy. Again, the Research Surveillance Centre suggested 28% reduction in bureaucracy. A lot of that is about a removal of contractual obligations. Some of it's about reduction in regulation, both professional regulation and organisational regulation. That's incredibly exciting, and general practice has gone on and done even better stuff as a consequence of not being bound down by unnecessary things that don't add to patient care. So I'd really love to see that continue, and I think general practice has almost rediscovered itself as a consequence of that happening.
Right, okay, and Lawrence, 30 seconds from you on what bit you want to keep hold of. I'll keep to the same question this time.
Yeah, so I would agree with Martin. Reducing the bureaucracy and the administration function has been great to do. In Northern Ireland, we've set up COVID centres, and actually GPs in Northern Ireland really showed themselves to be true innovators like we are. And this, we managed to set up COVID centres in a matter of weeks and have them open and running. And this has been terrifically positive for general practice and has been seen by government in a very high light. So it is that it shows that we can adapt quickly if we're given the resources. So that's a very exciting development.
Okay, thank you. And I'm being told I'm getting the 2-minute warning, which means I've got to start to wrap things up. So just a couple of quick plugs. First of all, I want to say thank you to everybody on the panel tonight for your time. And more importantly, thank you for everybody out there who's been watching and sent in your questions. We really relish this opportunity to hear from you and get your reflections on the work that the college has been doing. Please don't forget we've got our COVID resource hub, which is available on our website. I think one of the things that's changed over the last few weeks, 30 Euston Square, our headquarters in London, has been shut. So the threshold to college really has become a digital threshold through the website. And we've got an absolutely fantastic team who've been working around the clock for the college to make sure those resources have been up there. And we've had loads of feedback from the membership to say how gratefully that's been received. So thank you to the team for that. If you keep an eye out on social media for our RCGP Together campaign, that's celebrating the outstanding contributions that everybody's made to get us and our patients through this crisis. And we're asking people to send in a photograph of them at work in whatever way their new work is appearing. But just want to wrap up and say how proud we are of the membership and general practice, our teams, our staff at the college for the way they've handled these things. Thank you ever so much. Enjoy the rest of your evening, and we hope to see you next week on the next one of these events. Thank you ever so much. Take care.